Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering fundamentals/foundations of nursing. And to be specific, I'm going to be going over immobility and its complications. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. Go ahead and press that thumbs up button now. You're going to love it. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX reviews. You can book a review with me if you want a one-on-one tutoring session, a consultation session, or if you just want an audio lesson, you can go ahead and check all of those out or reserve your spot by going to my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my other social media platforms, such as TikTok, Instagram, and Facebook. So be sure to check me out there as well. Without any further ado, guys, let's get started. And the first thing we're going to take a look at this term mobility. So mobility refers to a person's ability to move about freely, and immobility is the opposite. It's the inability to move about freely. And so this video is all about the complications of not being able to move about freely, okay? So take a look down here, bed rest. This is an intervention that restricts patients to bed for therapeutic reasons. There are some diagnoses that the patient has that any activity, any ambulation can cause further harm. So we have to place that patient on bed rest. But bed rest comes with certain complications that we have to be watching out for. Let's keep going. If you scroll down here, look where my, what do you call this? Pointer, where my pointer is. It says the individual of average weight and height without chronic illness on bed rest loses muscle strength from baseline levels at a rate of 3% a day. That's telling us a lot. Let's stop right there. So it's telling us those patients who are on bed rest, those without even any other chronic illness, they're losing what? Take a look. They're losing muscle strength. What does that mean to us? We're going to be talking about this more, but the fact that we know that muscles, guess what? That's what helps keep your bones up. That's what helps you ambulate, right? Just keep that in mind. So already we're going to be thinking about that. We're going to be thinking about safety. Let's keep going. Let's see what it says. The term disuse atrophy, I have it underlined. You need to know that term. The term disuse atrophy describes the tendency of cells and tissue to reduce in size and function in response to prolonged inactivity, resulting from bed rest, trauma, casting of a body part, or local nerve damage. What does that mean? That means you don't use it, you lose it. Right? You're on bed rest. You're not moving about like you're supposed to. Those muscles are not contracting like they're supposed to. Guess what? They start to shrink. They start to get smaller. Not only the muscles, the tissue as well. When possible, it is imperative. I underline that word imperative as an important. When possible, it is important that patients, especially older adults, have limited bed rest and their activity is more than bed to chair. The older that you get, it's wear and tear of the body. Things start to break down. Your kidneys aren't working the way they used to. Your liver's not working the way it used to. Your muscles aren't strong the way they used to be, right? Do you think this type of patient, a patient that's part of the geriatric community, do you think that they can afford to be on bed rest for long? Absolutely not. And so that's why it's telling you that bed rest should be limited in these type of patients. Loss of walking independence increases hospital stays, the need for rehabilitative services, or nursing home placement. Let's keep going. Deconditioning related to reduced walking increases the risk for falls. I put a star next to that. Why? Because that is famous to be on a test question. Right? One of the biggest complications of patients being on bed rest, of those muscles getting shorter, of those muscles getting weaker. And let me not even get to the bones yet, because I haven't gotten to the bones. But one of the biggest complications and things we're going to be concerned about is falls. That patient's going to be weaker. Okay, so I put a star next to that so you don't forget. Systemic effects, all body systems, they work more efficiently with some form of movement. Let's go into the metabolic changes. This is the first type of changes we're going to be looking at as far as bed rest is being considered. Take a look up here where it says immobility. So immobility, not being able to move. Immobility disrupts normal metabolic functioning, decreasing the metabolic rate. Guess what? If the more that your metabolic rate decreases, do you think you're going to be burning a lot of calories or a little bit of calories? A little bit of calories. Everything is what? Slowing down. It can cause GI disturbances such as decreased appetite. It can cause decreased peristalsis. It can cause constipation. It says a deficiency in calories and protein is characteristic. And I didn't underline that word characteristic, but that's also a key word. You need to pay attention when you're studying. If you see that word characteristic, red flag should be going off, okay? A deficiency in calories and protein is characteristic of patients with decreased appetite secondary to immobility. That makes sense. I want you to think about it. The patient who is immobile, they're not moving the way that they're supposed to be moving. They tend to have a decreased appetite. We know that. Their metabolic rate has decreased. Think about it. They're not eating the proper amount of nutrients and minerals that they should. Of course, they're going to have decreased calories and decreased protein. What is the significance of that to us? Why are we concerned about the patient not having enough calories or protein? Well, guess what? Calories are needed for energy. You need energy for healing, right? Protein is needed for what? Muscle mass that patient's losing because they're on bed rest. Protein's also needed for what? Wound healing. So that's why the decrease in calories and proteins is so important to us. Let's keep going. It says right here, it says weight loss, decreased muscle mass, and weakness results from tissue catabolism, also known as breakdown. So when you see that word catabolism, that means to break down. Patients losing weight. Remember, they're not eating. They're not getting enough calories. They're not getting enough nutrients. They're not getting enough minerals because they're not drinking as well, right? They're not getting enough protein. They're losing weight. They're having decreased muscle mass. They're having weakness. All of this are result from the tissue breakdown. Let's keep going. Another metabolic change, I'm right here, another metabolic change associated with immobility is calcium resorption from the bones. Be very careful, guys. When you're reading, one letter will make the world of a difference. Resorption and reabsorption are two different things. When we see resorption, that's breakdown. So calcium resorption, the patient's losing calcium. When we see reabsorption, right, the patient's taking that calcium back. Their calcium will increase. So be very careful when you're reading. Another metabolic change that we see in that patient with immobility is calcium resorption, calcium loss. Calcium, guys, is supposed to be in the bones to make the bones nice and strong. That patient who's not moving will experience calcium resorption. Let me explain this to you. What keeps, well, not what, but one of the most important things that keeps the calcium in the bones and keeps the bones nice and strong is movement, weight-bearing exercises. When that's not happening, calcium leaves the bones where it's supposed to be, and it goes what? It hangs out in the bloodstream. Now the patient can have other issues. We'll get into that in a second. But for now, you need to understand, patient not moving can cause bone loss. It can cause the bone to become more porous. It can cause calcium to leave the bone where it's supposed to be. Immobility causes the release of calcium into circulation. So the calcium that was supposed to be hanging out in the bones is now hanging out in the bloodstream. Now imagine all that calcium hanging out in the bloodstream starts to clump up. Before you know, a patient's got kidney stones. But I'm getting ahead of myself. Let's keep going. It says pathological fractures occur if calcium resorption continues. I'm right here. As a patient remains on bed rest or continues to be immobile. The more that that patient's not moving around, the more that they're going to lose calcium from their bones. So the higher at risk they're going to be for fractures, because remember, it's the calcium that's making the bone strong. Let's keep going. Difficulty passing stools. Constipation is a common symptom. Let's stop right there. Think about it. The patient is not moving. Everything is slowing down. Remember, all the way up there when we're talking about metabolism, we knew that the metabolic rate decreased. Everything slows down. even peristalsis. So of course, this patient's going to be at risk for for constipation. Think about it. Peristalsis slows down. Their metabolic rate has slowed down. And remember, I just told you the patient loses their appetite. They're not eating the way they're supposed to, but they're not drinking the way they're supposed to either. So what happens? That stool that's in their bowels is just sitting there and starts to get hard. And it can cause a fecal impaction where nothing is moving. Okay. So constipation is common. Patient can have fecal impaction, which is accumulation of hardened feces. If this is left untreated, look, if left untreated, fecal impaction results in a mechanical bowel obstruction. Nothing is moving that partially or completely occludes the intestinal lumen, blocking normal propulsion of liquid and gas. Nothing's moving, but patients got to eat eventually. So stuff is going in, nothing's coming out. So what do you think is going to happen? We're going to have abdominal distension with all the fecal matter and gas is just building up. It makes sense. The resulting fluid in the intestine produces distension and increases the intraluminal pressure. Over time, intestinal function becomes depressed. Dehydration occurs. Absorption ceases, and this is bad because they're already not getting enough nutrients, vitamins, minerals that they're supposed to be getting in the first place, and fluid and electrolyte disturbances get even worse. So now we're dealing with a patient, their muscles are weak, their bones are weak, they are dealing with constipation, they're dealing with possible fecal impaction, they're dealing with possible dehydration and fluid and electrolyte imbalances. Let's look at respiratory changes. So guys, this is a big deal when the patient's on bed rest or they're immobile. So many things can happen to the patient. Respiratory changes. Patients who are immobile are at high risk for developing pulmonary complications such as atelectasis. This is collapse of the alveoli. I put a star next to it because you better know it. You're going to see it on test somewhere. And hypostatic pneumonia, which is inflammation of the lung from stasis or pooling of secretions. You need to know that as well. Those patients who are not moving, we're going to be concerned about lungs. We're going to be concerned about the patient getting pneumonia or the alveoli collapsing. Remember, alveoli, that's where gas exchange takes place, okay? What happens is the patient's not moving. Everything slows down, right? The secretions, even in the lungs, it just sits there. Bacteria loves moist environments where fluid's not moving, okay? So that is a perfect environment for bacteria to start to grow. So the patient absolutely is going to be at risk for pneumonia and collapse of the alveoli. Let's talk about cardiovascular changes. When it comes to cardiovascular changes, we're going to be concerned about orthostatic hypotension, increased cardiac, I'm right here, increased cardiac workload, and thrombus formation. Thrombus means clot. So let's talk about orthostatic hypotension first. So it says orthostatic hypotension, this is a drop of blood pressure greater than 20 systolic, 10 diastolic pressure, and symptoms of, you need to know these symptoms, I underlined it, dizziness, lightheadedness, nausea, tachycardia, pallor, fainting, when the patient changes from supine to standing position. If they're lying down and then they try to get up, they try to sit up or stand, and we see that blood pressure drop, that's what's known as orthostatic hypotension. The patient who is immobile, who's on bed rest, is at risk for orthostatic hypotension. You need to know those signs and symptoms that I underlined. So you better be teaching that patient, if you need to get up for any reason, let's say the patient not on bed rest, but they're immobile, maybe due to a fracture or something else, but they're allowed to get up to a chair. Even that, you're going to tell the patient to press that call button if they need to get up for any reason, or maybe they want to reposition so you can help them because you don't want a fall on your hands. Let's keep going. Down here, it says, as the workload of the heart increases, so does oxygen consumption. The more that your body's working, the more oxygen that it's going to need because it feeds on oxygen in order to work. So as the workload of the heart increases, so does oxygen consumption. We have a problem here. The workload of the heart's increasing, oxygen consumption's increasing, but the metabolic rate is still low. Do you see what's happening here, guys? Look what it says. Therefore, the heart works harder and less efficiently during prolonged periods of rest. Are you picking up what I'm putting down, guys? It's right here in front of you. Let's keep going. It says, patients who are immobile are also at risk for thrombus formation. Remember, thrombus, that's the clot, right? A thrombus is an accumulation of platelets, fibrin, clotting factors, and cellular elements of the blood attached to the interior wall of a vein or artery, which sometimes occludes the lumen of the vessel. Because guess what? If there's a clot there, how's the blood going to get through to go to the tissues that it needs to go to in order to perfuse those tissues? How's that going to happen? 3 factors contribute to venous thrombus formation, Professor D. Do I have to know these 3 factors? You absolutely do. Don't say I didn't warn you. Number 1, damage to the vessel wall, such as injury during surgical procedures. Because guess what? That damage to the vessel wall, naturally, when there is damage, your body's going to try to survive no matter what. So those platelets, the clotting factors, fibrin, guess what? Guess where they're going to go stick? And that clot is going to form right there, right? And then it gets larger and larger, and before you know it, there is occlusion for circulation. Number 2, alterations of blood flow, such as slow blood flow in calf veins associated with bed rest. Let me tell you, tell you about this slow circulation and why it's important, what the significance is. Your tissues survive off of oxygen, vitamins, minerals, nutrients, all of which is carried in the blood, right? If your tissues do not get these, your tissues will start to die. The patient will start to experience necrosis. Well, think about it. If you got a clot that's blocking the area, how is the oxygen, vitamins, minerals, nutrients, all of those that are being carried in the blood, how's it going to get to the tissues? Number 3, there's number 3 up here. It says alterations in blood constituents, such as a change in clotting factors. Maybe the patient doesn't have enough clotting factors. Maybe they've got, excuse me, let me back that up. I said maybe patient doesn't have enough clotting factors. That's the opposite. Maybe they have too much clotting factors, because it's too much clotting factors that will make a thrombus. If they didn't have enough, they'd actually be bleeding. So let me make that correction. Maybe the patient has too many clotting factors. Maybe they have too many platelets, because increased platelet activity will increase your risk for clots, right? So make sure you know those 3. Let's talk about musculoskeletal changes. It says restricted mobility sometimes results in loss of endurance, strength, muscle mass, and decreased stability and balance. All of that, you know what it tells me? Safety, that patient's at risk for falls. Them not moving around decreases endurance, strength, muscle mass, and balance. What is that telling you? Falls. This patient is a huge fall risk. Let's keep going. It also says impaired calcium metabolism and joint mobility. Muscle effects. Because of protein breakdown, the patient loses lean body mass during immobility. We talked about that already. Patient's going to have increased fatigue, increased loss of muscle mass. Prolonged immobility often leads to disuse atrophy. We talked about that disuse atrophy. Those muscles get shorter, they get weaker. Patients at risk for what? Falls. I put a star next to it. Don't say I didn't warn you. If you are studying immobility right now, you better know the biggest complications of immobility. You're going to be concerned about falls. You're going to be concerned about pneumonia. You're going to be concerned about that patient's respiratory status. You're going to be concerned about their metabolic status. Let's keep going. Let's talk about the skeletal complications. It says immobilization causes 2 skeletal changes: impaired calcium metabolism, the body's not using the calcium the way it should, and joint abnormalities. Because immobilization results in bone resorption, remember the bone's breaking down. I did not say reabsorption, don't get fooled. Let me repeat that. Because immobilization results in bone resorption, the bone tissue is less dense or atrophied, and disuse osteoporosis results. Osteoporosis, that's when the bone becomes porous. That bone has become porous just because it's not being used the way it's supposed to be used, right? You're supposed to be moving about. Let's keep going. When disuse osteoporosis occurs, the patient is at risk for pathological fractures. I put a star next to that as well. Make sure you know it. Don't say I didn't warn you. Let's keep going. I put a little note here on the side to remind you, osteoporosis, that means porous bones. Immobility can lead to joint contractures. A joint contracture is an abnormal and possibly permanent condition characterized by fixation of a joint. So this is bad nursing if the patient came in and they did not have a joint contracture and they're being discharged with a joint contracture. Okay, it's very important. You're going to be doing range of motion exercises with that patient. Disuse, atrophy, and shortening of the muscle fibers can cause joint contractures. When a contracture occurs, the joint cannot achieve full range of motion. One of the complications of a type of joint contraction, I should say, is foot drop. I'm going to show you what that looks like. But before I go, take a look. It says when foot drop occurs, the foot is permanently fixed in a plantar flexion. So here's what it looks like, guys. Okay, and here it says foot drop. The ankle is fixed in plantar flexion. Normally, the ankle is able to flex. So when the patient has foot drop, this is what the foot looks like. Look how it's down low. It's unable to flex up like this. Okay, the foot is staying in that lower position. That's the foot drop. Instead of looking like this, it's looking like this. All right, let's keep going. Urinary changes. Urinary elimination changes, I should say. I'm right down here. Urine is formed by the urine formed by the kidney needs to enter the bladder unaided by gravity because they're not standing. Sometimes they're not even sitting up, right? Let's keep going. Because the peristaltic contractions of the ureters are insufficient to overcome gravity, the renal pelvis fills before urine enters the ureters. This condition is known as urinary stasis. Now, before I go further, let's look at this visual illustration that they're talking about. So the kidneys, they're not showing the kidneys, but the kidneys are all the way, up here. Then the urine goes down the ureters to the bladder right here, and it's supposed to come out the urethra, right? And gravity is supposed to help this happen, but that patient that's lying down, that for this patient would have to overcome gravity. Sometimes it doesn't, so all the urine will sit right here instead of going into the bladder so it can be excreted through the urethra. What happens to fluid that just sits somewhere? Bacteria loves to grow. So this patient's at risk for what? UTIs. Absolutely. They're at risk for UTIs. They're at risk for urinary stasis. What is urinary stasis? When that urine's not moving. Anyway, take a look. We're right down here. So it says right here, it says this condition is called urinary stasis and increases the risk for urinary tract infection. And I just explained to you why. Renal calculi. I talked to you about the renal calculi, but I didn't say renal calculi. So I talked to you about how that patient who's not moving around, the calcium leaves the bone, goes to the bloodstream. Remember, the bloodstream goes everywhere, has to eventually go where? To the kidneys, starts to clump up. And before you know it, what? Patient's got kidney stones. Renal calculi, you see, I put a star next to, matter of fact, I put the 2 stars here. Why? and I put 1 star up here. You need to know that the complications, urinary stasis can cause UTI, renal calculi. Renal calculi, these are calcium stones that lodge in the renal pelvis or pass through the ureters. The same calcium that was supposed to be making the bone strong, but because the patient wasn't moving around, the calcium left the bones and went to the bloodstream. That calcium. Let's keep going. Let me make this a little bit bigger for you guys. Okay. Right here, it says immobilized patients are at risk for calculi because they frequently have hypercalcemia. Let's talk about this. Don't overlook that. I put a star next to it. Make sure you know it. This patient is not moving around the way they're supposed to be moving around. The calcium that was supposed to be making the bone strong has now left the bone and hanging out in the bloodstream, causing hypercalcemia because there's increased calcium in the blood. This is absolutely true. But there's also another reason for this. Remember, I told you that patient with immobility, they're not drinking the way they're supposed to. That them not drinking, being at risk for dehydration, only increases their risk for stones. Let's keep going. As the period of immobility continues, fluid intake often diminishes. When combined with other problems such as fever, the risk for dehydration increases. As a result, urinary output declines on or about the 5th or 6th day of immobilization, and urine becomes concentrated. This increases the risk for calculi formation and infection. Make sure you know that. Let's talk about skin changes, integumentary changes. It says here, immobility is a major risk factor for pressure ulcers. If that patient's not moving, guess what? They're not taking pressure off of bony prominences. Preventing a pressure ulcer is much less expensive than treating one. And guys, it's not only pressure ulcers, it's everything. When it comes to nursing, when it comes to medicine, it's always cheaper, easier, and more beneficial for the patient to prevent than to treat. Okay? Therefore, preventative nursing interventions are imperative. Let me underline imperative. Very important. So for this type of patient, you're going to make sure you're repositioning them at least every 2 hours. They're going to be on a pressure mattress. They're going to get frequent skin checks. You always want to prevent than to treat. A pressure ulcer is an impairment of the skin as a result of prolonged ischemia. This is decreased blood supply in the tissues. This usually forms over bony prominence, such as the elbow, the heels, the sacral area. When a patient lies in bed or sits in a chair, the weight of the body is on bony prominences. The longer the pressure is applied, the longer is the period of ischemia, and therefore the greater the risk of skin breakdown. The prevalence of pressure ulcers is highest in patients that are in long-term care facilities. Psychosocial effects. Immobility will affect the patient's sensory alterations. They'll have sensory alterations, changes in coping, social isolations, and they'll feel lonely. You'll see a lot of patients who've been on bed rest for an extended amount of time. Sometimes, they'll get delirious. That delirium will stem from an infection, usually a UTI, and the UTI stems from what? That bed rest, that immobility. So it's like a horrible domino effect. Some patients may have depression. Think about if you were stuck to a bed 24/7, how would you feel? Because immobilization removes a patient from a daily routine, he or she has more time to worry about disability. Worrying quickly increases the patient's depression, causing withdrawal. Withdrawn patients often do not want to participate in their own care. And let me tell you something, when it comes to nursing, you want the patient to do as much for themselves as possible. If you don't use it, you lose it. And guys, that is the end of this video. That is the most important things that you need to know as far as the complications of immobility. Let me know what you guys thought about this video. If you'd like me to continue the series and go over nursing care, nursing interventions, nursing teachings for the patient that is immobile, I absolutely will. But let me know in the comment section if that's something you'd be interested in. Let me know what you thought about this video or what you'd like to see me cover next. And let me know what format. Do you like this format where it's more of a lecture format? I'm teaching out of the book. Do you like my videos more where I'm doing the activities such as Kahoot? Or maybe you like my Q&A format, such as the videos that are released every Sunday, 1 p.m. Eastern Standard Time. So go ahead and sound off in the comment section. Let me know what you think. Let me know what you'd like to see next. And guys, don't forget, go ahead, reserve your spot for next generation NCLEX review by going to my website, nexusnursinginstitute.com. If you're not ready to go take your NCLEX, but you're currently a student and you need some help, check out the audio lessons I have available. Again, www.nexusnursinginstitute.com. Guys, thank you so much for watching. You guys will catch me on the next video.